Hi, so my name is Amy Cole, and today I will be discussing the goals and objectives of our work related to co-design approaches involving older adults, specifically related to developing a patient-centered preference tool for patients with hematologic malignancies. So first, before I get started, I would like to acknowledge and express my gratitude for the support and mentorship that I've received from our study team. So thank you very much to Dr. Lucas Mazur, Dr. Daniel Richardson, CHIP doctoral candidate Karthik Adapa, Dr. Amro Kashwina. And I would also like to thank Jennifer Bisram, UNC Health Sciences librarian, for helping with our search strategy for our systematic review. And I would also like to thank Paul Mihas, Assistant Director of Education and Qualitative Research at the Odum Institute, for his help in preparing and helping us prepare an interview guide for our study. So the agenda for today, this presentation, I will be discussing the research efforts specifically related to evaluating an electronic preference elicitation tool for older adults. And since we have limited time today, I will be focusing on specific aspects within each of these areas. So for our systematic review, I'll be focusing on how we align that with our study aims. We also talking about methods and the gaps that we discovered. Within our study protocol, I'll be discussing our research aims, methods, and study design. And within the study coordination, I'll be talking about our prototyping, recruitment efforts, and usability testing. And within analysis and reporting, I'm going to be focusing on phase 1 data specific to cognitive workload and usability. Before I begin, I would like to define what we mean by co-design, and that is an approach meant to elicit ideas and foster a non-hierarchical environment in which concepts, tacit knowledge, and the lived experiences of our stakeholders, including the target population, are applied to develop tools that meet the needs of the intended population. So focusing on the objective of a literature review, again, we wanted to align that with the aim, with our study aims. And again, we were developing an electronic preference elicitation tool for older adults. So refining our topic, we knew we wanted to evaluate the extent to which co-design approaches engage older adults throughout the full development lifecycle. After establishing a review question, a search strategy, inclusion and exclusion of criteria, as well as data extraction methods and our intended population, we then put that together and registered our review with Prospero. We looked at articles that were published in PubMed, Embase, and Scopus, and those articles were published between January 2010 and March 2021. Those articles were then uploaded to Covidence for screening purposes. And after a full text review, we found that we had 25 studies that met our inclusion criteria for the review. Looking at our data extraction and synthesis methods, we focused around 3 distinct areas, and that were co-design approaches, stakeholder involvement, and electronic healthcare tools. Within co-design approaches, we wanted to extract information relative to the terminologies and definitions that were used, the theoretical frameworks that were used within the studies, and the iterative development, and whether or not the studies were employed phases, and if so, how many phases they employed. Within stakeholder involvement, we wanted to extract information about participant types, so whether or not we were looking at patients, the general population, caregivers, and then with types of involvement processes, we wanted to be able to categorize that information. And so with that, we pulled out Leonin's framework for categorizing the types of involvement processes. And similarly, we used the Vaughan's framework for pulling out the levels of participation. And with both of those, I'll get into more detail about what those frameworks look like. Within electronic healthcare tools, we utilize the World Health Organization's classification of digital health interventions to classify the types of electronic healthcare tools. And we use Herman's framework to look at the older adults' needs that were addressed when they utilized electronic healthcare tools. And lastly, we pulled out user testing, and that was looking at the subjective and objective measures that were utilized and whether or not those measures were validated. For the purpose of today's presentation, I'm just going to be focusing on stakeholder involvement. And again, what we're looking at is the types of involvement processes and the levels of participation. So looking at the types of involvement processes, again, we utilize Leonin's framework, which categorized 4 distinct areas. And that was participatory design, product design, software prototyping, and contextual design. Within levels of participation, again, we use Vaughan's framework, and that was looking at 5 levels of participation, from inform to consult to involve to collaborate to empower. And I'll get into the more granular level of these here in just a minute. Giving you some general characteristics of our included studies. Again, we had 25 studies that were included in our review. Participants' age range was from 60 to 91, with a mean of 71.4 years of age. The number of participants ranged from 7 to 135, with a mean of 40.8. The study settings were in a variety of locations, including remote Zoom sessions. And the study locations were in several different countries, with the majority being in the United States. Specifically looking at the results based on Leonin's framework for the involvement processes, we found we had 151 involvement processes that represented those 4 distinct stages. So within each of those areas, looking at first participatory design, you see the various involvement processes that were included, and looking at things like interviews and think aloud sessions. Within product design, we had areas of involvement processes such as user stories and heuristic evaluation. And within functional prototyping, we did have, or within prototyping, we're looking at functional prototyping. And this is distinctly different from what we see here in product design under medium fidelity, or under participatory design where we're looking at low fidelity. And lastly, looking at contextual design, we have contextual inquiries. We did find that each study utilized between 2 to 11 involvement processes, with a mean of 6 processes per study. And while we found inconsistency in the utilization of these involvement processes, we did see that 70% were using both interviews and medium fidelity prototyping. We also found that less than 20% were utilizing contextual inquiries and use cases. Looking at how we classified studies based on Vaughan's framework, we did see that 25 of the studies were both classified as inform, and 25 of the 25 were also classified as consult. Vaughan defined inform as the sharing of information among community members, and consult is defined as soliciting feedback from stakeholders at a particular decision point. 24 of the 25 studies were classified as involve, which was defined as participants providing feedback throughout the full development process. And 16 of the 25 studies were classified as collaborate, which was defined as participants being involved as co-leaders and having an equal role in decision-making. And lastly, we had 15 of the 25 studies classified as empower, which was defined as participants taking a lead in engaging others on the usefulness of the tool. We then took Leonin and Vaughan's framework and combined them to evaluate how the core involvement processes relate to the 5 levels of participation. We mapped the levels of participation that were reached within each study against this particular involvement processes. And as we'll see in a minute, some of the involvement processes may relate to higher levels of participation than others. But before I get into those results, we'd just like to suggest that we're looking at involvement more as a process, and that additional exploration is needed to determine the extent to which a participant's greater understanding of the tool could contribute to richer feedback, meaning the level of participation should not just occur in one direction, but is instead bidirectional as depicted here, meaning those who participate at higher levels will have a greater understanding of the tool, and that will result in a greater contribution to the development of the tool. Looking specifically at the mapping, where we have taken the levels of participation and mapped those against the involvement processes, we can see the 25 studies that were classified as inform, measuring those against those that were classified as empower. We see that we had an increase in contextual inquiry from 4 to 5%, and in functional prototyping from 10 to 14%. We also saw a decrease in participatory design from 60 to 55%, and in product design from 24 to 23%. But this becomes much more distinct when we look specifically at the separation between the levels of empower, of the 15 studies that were classified as empower, versus the 10 studies that were classified as having not reached the level of empower. And here we see a change in participatory design from 55 to 69%, and in functional prototyping from 14 to 2%. And while our systematic review covered a lot more information, to give you a conclusion of what we discovered, the evidence suggests that co-design approaches do aim to involve end users in the development of electronic healthcare tools. However, we did find gaps in the evidence to support the levels at which older adults should be involved and the extent to which this involvement can increase the user's knowledge of the technology, either limiting or encouraging their collaboration and empowerment. To ensure studies are optimizing the involvement of older adults when developing electronic healthcare tools, improving existing co-design frameworks to meet the needs of older adults should be evaluated. Going into our protocol manuscript, the primary objective of our study was to evaluate a co-design approach to evaluate the perceived usability, cognitive workload, and performance for both a discrete choice experiment and best-worst scaling prototype, and to analyze the results from user testing for future development of a functional electronic patient-centered preference elicitation tool. We designed a mixed method study that would ultimately engage 4 different participant types, including healthy volunteers, patients, caregivers, and healthcare workers in usability testing and qualitative interviews to evaluate both prototypes. Insights from Dr. Richardson's previous research efforts regarding both best-worst scaling and discrete choice experiment methods, as well as our systematic review, were incorporated into the study protocol. The objective of phase 1 was to evaluate and compare standards on the perceived usability of the discrete choice experiment and best-worst scaling, as well as the cognitive workload of healthy volunteers when interacting with the electronic healthcare tool. Focusing just on phase 1 at the moment, we had recruited 15 healthy volunteers consisting of 3 cohorts. Each cohort engaged in usability testing, in which we incorporated Leonen's framework. And after user testing sessions, we then analyzed the data, incorporated that into our design, rebuilt our prototype, and presented to subsequent cohorts. From our systematic review, we saw that involving older adults in the design process can positively impact their learning, sense of participation, and improve the development of the electronic healthcare tool to better reflect the needs of the population. So phase 2 does include bringing in both patients and caregivers, as well as healthcare workers. Again, we ran through the usability testing, we will be conducting the usability testing, analyzing the data, redesigning based on that feedback, rebuilding the prototype, and again, presenting this to those subsequent cohorts. When we move to phase 3, we'll be focusing on performance of the tool as well. In phases 2 and 3, we do intend that our findings will help differentiate and validate the usability, cognitive workload, and performance and alignment of patient preferences for both the discrete choice experiment and best-worst scaling methods. Looking at the validated measures that we will be using, there's a series of assessments mapped against the type of participant. Our study is going to include user testing and qualitative interviews to obtain participants' comments and feedbacks on the information, features, navigation, and design of both prototypes. We're also evaluating memory skills, health literacy, and conducting geriatric assessments to analyze predictor variables. By the conclusion of this work, we should have enough evidence to support development of a functional electronic healthcare tool. Moving to our study coordination. Again, we needed to develop and refine 3 distinct medium fidelity prototypes. To do so, we utilized Adobe XD. And to give you an overview of the 3 different prototypes, I've been referencing the discrete choice experiment and best-worst scaling methods. To give you an overview of each of those, the first, the discrete choice experiment, sometimes referred to as a multi-profile case. Here, we're asking patients to select a profile or preferences based on 5 distinct attributes. And within each of the drug A and drug B columns, you'll see that the levels of each attribute will vary. As the participant goes through each of the questions, the attributes will remain the same, but the levels will vary. And within each question, they'll be asked to select whether or not they prefer drug A or drug B. Moving on to best-worst scaling, we're looking at a profile case. Again, they have a profile of attributes Again, the levels are varying within each, but here we're asking them to select one of these that is most important and one that is least important. As they go through this question series, the attributes will remain the same, but again, the levels will vary. And lastly, we're looking at another best worst scaling referred to as object case. Again, we're asking them to select one item that is most important and one item that is least important, but here we remove the levels and we're just focusing on the attributes. While there's 4 attributes here, they would see 7 total, and those would vary throughout the question series. Again, today I'm focusing on phase 1 data, and for that, we were recruiting healthy volunteers. We utilized Research for Me, an initiative of NC Tracks, in which healthy volunteers were able to read through our study information and determine if the study was a good fit, and then contact us directly through email. Once we consented the healthy volunteers, we then scheduled the time for them to come into the lab. Once we met with them, we explained the prototype testing procedures, which included audio and screen recordings, and then we randomly presented them with either a best worst scaling or discrete choice experiment prototype. Once we handed them the prototype, we asked them to think aloud as they walked through the prototype, and upon completion, they completed a PSSQ questionnaire to evaluate usability. They also completed a NASA TLX questionnaire to evaluate cognitive workload, and then we conducted semi-structured interviews. After completing the first prototype, they were then presented with the alternate prototype, and again went through the same series of assessments. And then lastly, we were interested in looking at their working memory, so we conducted a digit span assessment, and we were also interested in health literacy, so we conducted an e-HILS assessment. Upon completion of the user testing, the study team member then entered the data into the REDCap database, and the volunteer received compensation for their participation. Moving into the analysis and reporting, again, focusing on phase 1, looking at the PSSQ scores, we broke those down by prototype, by the 3 distinct prototypes. And looking at that, we wanted to evaluate this based on standards. So we chose to evaluate based on Soro and Lewis's standards. And looking at this, our overall PSSQ does report that we have acceptable usability levels. Looking at our cognitive workload, again, we chose to use the NASA TLX questionnaire. Again, we're breaking this down by 3 distinct prototypes. And evaluating the global TLX score here, we see that we have acceptable, We see that we had acceptable cognitive workload levels for both of the discrete choice experiment and best worst scaling prototype. Looking at the qualitative analysis, again, we're looking at 15 healthy volunteers. They were broken up into 3 cohorts of 5 volunteers per cohort. Here we were looking at our semi-structured interviews that we conducted, in which we were eliciting feedback on whether participants understood various aspects of the tool, including the definitions of the attributes, their ability to distinguish between the levels of the attributes, and which question series they preferred, either the best worst scaling or discrete choice experiment. Based on our data analysis, 100% of our participants indicated that they both preferred both the discrete choice experiment and best worst scaling were not challenging to complete. And while 100% of our participants reported that they understood the attribute definitions well enough to complete the prototype, 33% did indicate that they needed to reference the definitions to complete the prototype. Overall, we saw that 74% of our participants preferred the multi-profile case, 13% equally preferred the object and multi-profile case, and 13% preferred the object case. Insights from our qualitative data indicated that both prototypes were easy to complete, but access to the definitions needed improvement. We're currently developing an affinity diagram for thematic analysis, which will be incorporated into phase 2, which will involve patients, caregivers, and providers. Through our efforts, we have completed and submitted a systematic review for publication consideration to BMJ Open. We have also worked on our protocol manuscript, developed and revised 3 distinct prototypes, recruited 15 healthy volunteers, conducted usability testing with those healthy volunteers in the Human Factors Laboratory, and we also submitted an extended abstract to HCI International Conference that outlines the results of our phase 1 analysis. Gaining an understanding of our research methods, study designs, and analysis and reporting was beneficial to both our team's research efforts and my professional development goals. Working on the systematic review provided me with a stronger understanding of the value of the methods and frameworks. I gained an appreciation and desire to investigate how relevant methods can be incorporated into both my academic and professional work. I gained insight into the complexity of study design and the value of understanding all of the components to ensure you're measuring what you intend to measure. Working on the protocol manuscript allowed me to think through the study design process, evaluate processes, and ensure we use appropriate methods and measures. I was able to gain additional skill sets in prototyping and usability testing. And after completing testing for our first phase, I was able to gain skills in analyzing and reporting study data. I've been very fortunate to have the opportunity to work with a really great team, and I have been extremely grateful for their support and mentorship. Thank you very much.